I'm Emma MacIntyre.
I'm Allie McCarthy.
I'm Emily Newman.
And I'm Emma Sheils.
And we're working on designing a growing rod for the treatment of early onset scoliosis. Scoliosis is a spinal deformity that affects between 6 and 9 million Americans and occurs when the spine is deformed into a C or S shape. Specifically, early onset scoliosis affects children under the age of 10 and affects nearly 5,000 Americans. Scoliosis is diagnosed by the Cobb angle, as seen in the graph at the bottom of the slide. Before the age of 5 is critical for thoracic spine growth, as well as between the ages of 5 and 10 is very critical for alveolar development.
Severe scoliosis can cause hindered lung development and stunted thoracic growth, as well as pain and difficulty performing everyday tasks. Spinal fusion is common in adults and involves the surgical immobilization of the affected vertebrae. This isn't ideal for children because they're still growing, and 40% of early fusions require reoperation. Therefore, surgeons really try to wait till the last moment before they perform this surgery on children. There are treatments that allow for growth of a child with scoliosis, including growing rods and guided growth, but these treatments often involve repeat surgeries as well as spontaneous fusion and stunted growth. Therefore, there's a need for a patient-controllable and growth-compatible implant to correct early onset scoliosis.
Our device couples a polymeric growing rod with a piezoelectric wirelessly operated lengthening mechanism. Growing rod is made out of PEEK polymer, which provides mechanical stability to the spine as it's growing, while also promoting flexibility to provide increased range of motion. The rod is held in place by titanium alloy pedicle screws that are surface blasted treated to provide surface roughness and promote osseogradation and prevent screw loosening. The lengthening mechanism is housed in a stainless steel casing, which has a FitBone technology screw that converts electrical signals from the receiver to mechanical stress to distract the lengthening rod in a controlled mechanism. The wirelessly controlled device uses AC current to transmit radio frequency to the implanted receiver. Then, using the piezoelectric polymer, electrical signal is converted to mechanical stress to distract the rod and lengthen it as the patient grows. By increasing the frequency of distraction and increasing the flexibility of the polymer, the system hopes to more accurately emulate physiological growth.
The device will be implanted in the patient between the ages of 5 and 10. A 1 millimeter distraction will be performed per month, and X-rays will be taken of the patient's back every 6 months to validate this distraction rate. X-rays can also be taken of the patient's wrist to confirm growth and to determine when the patient has stopped growing. At this point, removal of the device can occur and the spine can be fused into its new straight shape.
When designing this implantable RF device, various wireless communication specifications must be considered. First of all, the frequency band used will be between 402 and 405 megahertz. This band has been seen to be good for signal propagation within tissues and organs of the body. Secondly, the specific absorption rate must be below 1.6 watts per kilogram for 1 gram of tissue to prevent any radiation exposure to the tissues that would be harmful. Lastly, a transmission and receiving current must be less than 6 milliamps to prevent harm to the body. In terms of benefits and costs of the device, we will be using a PEEK polymer that is more flexible and will prevent spine stiffening seen in other devices. Secondly, we're going to be using a programmable distraction rate, which will be better for mimicking physiological growth as it can be tailored to the patient, as well as it will allow for less frequent outpatient visits. Secondly, due to the titanium screw surface modification, this will result in less of a risk for screw pullout. In terms of cost of the device, we will have to be considering the manufacturability of the device as well as the cost of rod fabrication. Also, due to the wireless RF communication of the device, we have to be aware of any hacking considerations that might arise. We also have to consider any FDA approval that the device must need to go through, as well as repeated x-rays that may be needed for monitoring of the device.
Currently, the golden standard for early onset scoliosis is growing rods, and these are mainly adjusted as the child grows through invasive surgery. MAGAC rods follow a similar concept, but they are controlled externally using magnets. Risks of both of these include chance of infection, implant movement, metal corrosion, nerve injury, inadvertent spinal fusion, and mechanical failure of the lengthening mechanism. Stapling and tethering both function by inhibiting growth on one side of the spine while allowing the other side to grow. Stapling uses shape memory alloys, and tethering consists of titanium screws and a flexible cord. Stapling and tethering are both less invasive, but they are not ideal for cases of severe scoliosis. Our device aims to incorporate different aspects of the current methods by combining the strength and stability of the MAGAC and growing rods and the range of motion and flexibility of the stapling and tethering. Here are references.